Hello and welcome to my presentation, Suicide Prevention and Intervention in the Military. My name is Amy Blackman. I'm a graduate student at Colorado State University in the Military and Emergency Responder Psychology program. So thank you for tuning in. Death by suicide is the highest it's ever been among U.S. military service members and veterans. It's increased approximately 50% since 2007. The White House is concerned. In 2022, they issued a report stating suicide among service members, veterans, and their families is a public health and national security crisis. So that is pretty serious stuff. All right, let's talk about suicide among service members and their family members. I've just done a few highlights here. We're going to look at calendar year 2020, 21, and 22 for both military family members and service members. So let's just start with military families. In calendar year 2020, 202 military family members died by suicide. That was 133 spouses and 69 dependents. Of those, 60% the method of suicide with firearm and for spouses, and then 55% for dependents. Looking at calendar year 21, for service members, 519 service members died by suicide, 328 active, 74 reserve, and 117 in the Guard. And 70% of all service members took their own lives utilizing a firearm. Calendar year 2021 regarding family members, there were 168 total family member suicides, with 114 of those being spouses and 54 being dependents. First, let's look at the, and it looks as though, and I do think I point this out, that 61% of spouses and 56% of dependents utilized a firearm, which I believe is higher than, if I'm remembering right, it was higher, or was it lower? We'll see. Anyway, for service members in 2022, pardon me, I have a little cold, 492 total service members, 331 active, 64 in the reserve, and 97 Guards members. 69% of all of them used a firearm. Very concerning. All right. So I'm not going to really just go through these. I just wanted you to notice how similar the age distribution is, the age group distribution through these, and the race distribution, the rank distribution. Yeah. All right, this set here also seeing disproportionate sex distribution that mirrors suicide statistics in general. Age group still, younger folks, white, enlisted. All right, here again, majority male. The Air National Guard was kind of the only odd statistic in that the age group was a bit older. But as we see, similar to the profile of the U.S. Armed Forces, the majority of the service members that took their own lives last year, calendar year 22, were male, under 30 or 30 years old or younger, white, Caucasian, whichever, enlisted, and never married. So particularly with the male, 93.1%, and then enlisted, 90.9%. Those, I wouldn't say shocking statistics, but just really imbalanced. Good news, though, there were fewer military service member suicides in 2022 than in 2021, 27 of those. And with family members, there were 34 fewer suicides in 2022 than there were in 2021. I don't know if those seem like small numbers to you, but they don't really seem small to me, and um, I think it would really increase the percentages as well, so, or decrease the percentages. More good news. Two of the three U.S. Armed Forces components had fewer military service member suicides in, so last year, calendar year 22, than they had in calendar year 2021 and 2020. The only blip in that data was active component or active duty, um, but still the count was significantly lower between CY22 and CY20 for active component. Otherwise, all of the components had fewer suicides of military service members than they had. So again, very good news. Alrighty, let's talk about veterans. In 2020, so the most recent data that is at least available through the Department of Veterans Affairs is calendar year 20. So those are the most up-to-date statistics that I have for veterans. So anyway, in 2020, suicide was the 13th leading cause of death among veterans overall, and it was the second leading cause of death among veterans under age 45. So you see that kind of mirrors those statistics of with the service members being 30 years old, or the majority of the service members being, among other demographic stats, 30 years old or younger. So again, it's something we need to, I don't know, probably focus on. But the same could be said for elders and elder veterans, but that's a different project. Anyway, so VA lethal methods, there's been a little bit of a change. We see the percentages aren't super great, except under suffocation. But from 2019 to 2020, suicide mortality rates decreased for firearms, poisoning, and most significantly, suffocation, while increasing for other types of lethal means. All right, let's take a look at lethal method firearm for veterans, CY19 to CY20. In 2020, firearms were involved in 72.1% of suicides by male veterans, which was up from 70.6% just the year before in 2019. In 2020, firearms were involved in 48.2% of suicides by female veterans, which was down from 48.4% in 2019. Big news! In calendar year 2020, there were 6,146 total veteran suicides, but that was 343 fewer than in calendar year 19, which I think is extremely encouraging for the future. On top of that, well, I mean, it's good news, but it's also, depending on how you look at it, kind of sad news. 2020 had the lowest number of veteran suicides since 2006, which obviously is wonderful, but again, all those years between 2000, essentially 7 through 2019, I mean, obviously had higher, much higher. Still encouraging. All right, so from CY, this is the only time I really wanted to do an expanse of data from CY01 to CY20. So even though there were 24.6% fewer living veterans, the percentage of veterans that were engaging in healthcare through a VA facility anyway, so that increased 55% from 3.8 million in CY01, jumping to 5.9 million encounters. It's my humble opinion, and as a clinician in training, I think increased treatment engagement is most likely, I said could because I wanted to reserve that, but is likely the reason for lower veteran suicide rates. So we all need to keep it up. So regarding evidence-based suicide assessments, I believe very strongly that we need to learn them really, really well. So we give clients the opportunity to narrate their suicide story without us um, looking like we're going down a checklist, for lack of a better description. First suicide assessment I want to talk about is the PHQ-9, or the Patient Health Questionnaire 9. It is empirically supported. Um, all of the assessments that everything I talk about in here basically is empirically supported. But the PHQ-9 is a self-report scale that assesses the frequency of depression within the preceding 2 weeks. So I do like how that is very concise in the timeline. And higher scores on item 9 correlate with the increased risk for suicidal behavior. So we see here the graphic of the actual questionnaire. It's very easy to administer or to have them do on their own. If a client screens positive on item 9, thoughts that you would be better off dead or hurting yourself in some way, then further evaluation is generally conducted utilizing the Columbia, as we call it, or the Columbia Suicide Severity Rating Scale, the CSSRS. So the CSSRS was designed to measure the severity of suicidal ideation and suicide behaviors. Multiple researchers have produced findings supporting the CSSRS's predictive validity and utility. So it's widely used and has been for a long time. I'm quite sure we have all seen the CSSRS, but I just wanted to, a lot of the reason I wanted to show this is the PHQ-9 is okay, in my opinion, for self-administration, but I don't think that the Columbia I don't believe it's best practice or advisable to have this self-administered. It's chunky, it's wordy, it's clinical, and it just needs to be done by a clinician. If there's no time to do it, don't self-administer it, or don't have them self-administer it. All right. So yes, you glean wonderful information from the CSSRS for sure, but it obviously can be pretty time consuming. All right. The Comprehensive Suicide Risk Assessment, or the CSRE, admittedly is my personal favorite. I do think it's a great tool to use in conjunction with other assessments, the PHQ-9 and the CSSRS, but it's also comprehensive enough to be used just by itself, because it does pick up, it's still picking up warning signs, it's still picking up risk factors and protective factors, but more so than the CSSRS. The CSRE includes evidence-based factors to gather information that will inform an impression of either acute, which is minutes to days, and chronic, which is long-term risk. See here that graphic. Pretty detailed, but I just find it easier to navigate than the Columbia. Here again. Again, looking at, suicide attempts past, what the current ideation looks like. How close are we to this? What kind of preparatory behavior is going on? The warning signs, obviously. Things we're observing in their reporting. Risk factors, of course, we need to identify those. And as we see, I'm not going to go through them all, but I thought it was interesting that in 2019, the VA, along with the DoD, said that risk factors for suicide included current suicidal ideation, but in the U.S. Department of VA, their own publication just a few years later, I maybe I'm missing it. I don't think so. I've been looking at this for a while and I just don't see it on there. So I wanted to make sure that current suicidal ideation was something to note as a risk factor. All right. Now, yes, the CSRE has this list of protective factors and reasons for living. I think depending on the client you're working with, it's also a good idea to utilize the reasons for living inventory. That's going to look at 6 subscales: survival and coping beliefs, responsibility to family, child-related concerns, fear of suicide, fear of social disapproval, and moral objections. There's 2 versions of the reasons for living. There's a 72 item, I believe, and a 48 item. So yeah, just depending on what your time looks like. But I do think it's important to utilize and have a pretty deep conversation about the reasons for living. All right, at the end of the CSRE, and all of the appendices, I should say, are attached to the actual instrument, which is great. It just gives you the opportunity to provide clinical impressions, and then based on whether it's high, intermediate, or low acute, high, intermediate, low for chronic suicidality, it gives you instructions right there on the instrument um, as to what to do. I also, of course, will always say clinical consultation is a great idea, but it's great to have this attached to the tool. A little sip of the water there. All right. So the last thing about the CSRE, pardon, it is suggesting a risk mitigation plan. And it gives additional risk mitigation suggestions in Appendix C, also very handy. The only one, well, not the only one out of these, but the one I want to talk about now is safety planning. If you have an opportunity with your suicidal client to bring their loved ones and or caregivers into the conversation, that is ideal. All right. Safety planning, best practice, evidence-based, clinical intervention that should always be co-authored by the mental health professional and clients. Absolutely. Never want to hand somebody, a suicidal client, a template and say, here, fill these boxes out, and we may or may not chat about it if we have time in the session. So yeah, proper safety planning, appropriate safety planning has been shown to reduce suicidal ideation, suicide attempts, and psychiatric hospitalizations, which saves all of us. The Stanley Brown Safety Plan is my go-to. It mirrors the, well, I'm not sure what came first, the chicken or the egg. I'm pretty sure Stanley Brown did, because this was, they came up with it in 2012, and then at least the VA resource that I found. As you see the steps, let's see, step 1, warning signs, they're all the same. So it's, obviously a great intervention tool to use with clients that are experiencing acute or chronic suicidality. And it has actually been considered not just valid enough, but comprehensive enough. If you have to use it with a quickness, then it can be used as a standalone intervention, which is great. But I also think it adds to the validity either way around, that these steps of what the VA suggests a safety plan needs to consist of is exactly what the Stanley Brown Safety Plan is and does. I wouldn't wait to do a safety plan. I think it's best practice to co-create co-author the safety plan pretty soon into the therapeutic relationship, particularly depending on initial presenting problems. But suicidality is dynamic, as we know, and it could come into play at any time. So having that very valuable resource of safety planning there to help is, I find that to be just best practice. And, honestly, if you are going through this entire process that I've been explaining, you already have a lot of information for the safety plan that's been gleaned from the PHQ-9, the CSSRS, and the CSRE. And what's great about the safety plan at the end, as we saw, it is saying, okay, we need to talk about lethal means. We need to protect the environment. We need to keep the suicidal person safe. Let's talk about lethal means. The acute phase of a suicidal crisis is often brief, minutes to days, as we said, and many suicide attempts are impulsive. Research has seen that. Survivors have said that. So building in time and space between impulse to act and the means to harm oneself saves lives. It just makes complete sense. According to one case control study, almost 1 in 4 approximately attempted suicide within less than 5 minutes of their premeditation. Okay, and then in another study, 47.6% of patients reported a time span of 10 minutes or less for the suicidal process, time between the first thought of suicide and the attempt. So again, building in time and space between the impulse to act and the means to do so can save lives. Just brought the statistics back from the other graphics before, just reminding us that, the majority of service members and family member suicides are committed via firearm. So, like the little graphic says there, the little dude says, it shows the importance of lethal means safety in the military community. Absolutely. Just some notations here. Thought this was kind of cool that there's just a lot of information out there, and you don't have to look very far. The VA and the DOD, the Defense Suicide Prevention Office, everybody takes this very, very seriously. Lethal means safety. It just saves lives, period. We got to get the guns away, locked away, out of the hands of suicidal folks. What I thought also, kind of what I did with the other, was in comparison to the tips of the Defense Suicide Prevention Office, the VA and the DOD said store firearms disassembled or remove the firing pin. And I like that. I don't think it's enough sometimes. You see the range there for the VA and the DOD. It's kind of in the middle range if it's a lower suicide risk as opposed to a higher suicide risk. Store firearms disassembled or remove the firing pin. I'd say that's just good practice. All right, this is a great graphic, all in one. Obviously, some military service members and veterans do not want their firearms removed. Sentimentality, value, utility, just whatever reason, whatever personal reason, they don't want them removed. So we have these safe storage options, cable locks, and then of course locked cases, safes, lock boxes, so on and so forth. And it doesn't make much sense to have these things and have the suicidal person with the key or the combination. So try to get those out of the access of the suicidal client. All right, so we know that the only lethal means obviously is not firearm. 3 out of every 10 female veterans took their own lives by intentionally poisoning themselves via just taking too many medications intentionally. So yeah, 3 out of every 10 female veterans that's their choice. And this graphic shows also suffocation, other means, I would say probably hanging, um, jumping off a bridge, something like that. Suffocation also is not just putting a bag over one's head, but also CO2 intoxication, sitting in your car in a locked garage, or doesn't have to be locked, I guess, but probably is if this is a pretty serious attempt. You don't want anybody um, to bother you or interrupt you. So anyway, I'm not going to go through all of these, just some lethal means of medication safety examples. Not everybody thinks about um, the fact that you can overdose on almost anything. Tylenol, in particular, is one that the Department of Veterans Affairs has been um, concerned about. Just ridiculous amounts of Tylenol being taken in attempts. Also, of course, if you have somebody that is having issues with opioids, then having naloxone education, having um, Narcan available, several kits for just in case, that will save lives. Um, as for blister packaging, limit the amount of medication that they have access to. Get family members involved. Same as with safety planning. This is all part of safety planning, I think, essentially. Try to discontinue. Never flush medications. There's bins at every pharmacy I've ever seen, and certainly at the VA, to take those expired medications, but do not flush those. Well, talking with military service members and veterans can be hard. Talking with any suicidal person can be hard. Um, I thought the GROW framework here was pretty handy, though. Again, I'm not going to go through the entire thing, um, but GROW stands for the G is get ready, R is reason for the discussion, O is offer brief advice, and the W is we're here to help. So I really enjoy this. I think it's very handy. It gives really good suggestions of things to say, not to say, just the advice of being prepared before you breach the conversation with a suicidal individual. This isn't just to be used by clinicians by any means. This can be used by anyone, as can my next slide here. The save strategy, I really enjoy. I made these save cards and with the intention of having them be printed dual-sided and to have them laminated and distributed. I find it to be extremely handy. I love that the Defense Suicide Prevention Office had the information for me to adapt, but I think these are just really good. Save, S is signs of suicidal thinking. A is ask the most important question of all, just straight to the point. Are you thinking of killing yourself? V is validate the veteran's experience. Yes, that's clinical, but that's for everyone also. And then E, the last, is encourage treatment and expedite getting help. So these are great. It's great information, I should say. Alrighty, getting near to the end here. Suicide prevention strategies. Let's talk about them. We need to treat mental health and substance use disorders with evidence-based psychotherapy. We know that, and we see a lot of co-occurring disorders, mental health disorders and substance use disorders. We need to take care of both. I pulled the most comprehensive set of statistics for veterans. I couldn't find as comprehensive a list for service members and certainly not military service members, but I definitely wanted to post just to give us an idea, like from depressive disorder at 35.2% to schizophrenia at 4.5%, which frankly between us, I think that seems a little low. But I'll go with it. Valid statistics. But we're seeing anxiety, PTSD, alcohol use disorder, cannabis use disorder, opioid use disorder, and of course, bipolar personality disorders, and as I said, schizophrenia. So this is what the veterans are showing us. This is what those that died by suicide in 2020 had been diagnosed with. Cognitive behavioral therapy, been around a long time, widely used, evidence-based, structured, time-limited, most of the time. And this is utilized to directly address suicide risk. So very, very handy to, learn CBT frontwards and backwards and be able to utilize it with all clients, but particularly with suicidal clients. The goal is to teach suicidal clients to identify and change problematic thinking or their core beliefs and their behavioral patterns, usually pretty self-destructive. CBT expects the acquired ability will positively impact the client's emotional experiences, change the way they see things, themselves in particular. At the end of CBT, generally speaking, a relapse prevention plan is co-authored with the client. It's much like a safety plan. And the good thing is CBT has been shown to provide critical benefits to suicidal clients, including decreased incidence of self-harm, which obviously is what we're looking for there. I have a little more information here for problem-solving therapy. I really appreciate problem-solving therapy. I just like the brevity, how it gets down to it. Let me just read through these. PTSD is for clients experiencing depression and distress related to inefficient problem-solving skills. It's aimed at improving a client's ability to cope with stressful life experiences through active problem solving. And the primary focus is to empower clients to learn how to solve problems on their own. Problem-solving therapy teaches clients problem identification, efficient problem solving, and managing associated depressive symptoms. And it helps to resolve depression by re-engaging clients in active problem-solving and activities. Problem-solving therapy has been shown to reduce repeat self-directed violence and significantly reduce suicidal ideation. All wonderful things. All right, and lastly, problem-solving therapy involves 7 distinct stages that take place throughout 4 to 12 sessions, so it can be brief, it can be a bit longer, and it can also be individual or group therapy. Now, or a combination of both. If it's individual, it usually goes about 40 minutes. Groups are about an hour and a half. The first step is selecting and defining the problem. Second, establishing realistic and achievable goals for problem resolution. Third step is generating alternative solutions. The fourth step is implementing decision-making guidelines. 5, evaluation and choosing solutions. 6, implementing the preferred solutions. And then the last step, evaluating the outcome. All great. All right, so I just posted a few resources available to assist with suicidal ideation, suicidal crisis, and stuff like that. We've got the crisis line, of course, Colorado Crisis Services. I'm in Colorado. The Veterans Crisis Call Center, War Vet Hotline, the National Call Center for Homeless Vets, the Colorado Coalition Against Domestic Violence. Again, I live in Colorado, so I have these more centered. Always the Veterans Crisis Line, the Rape, Abuse, and Incest National Network, or it's RAIN, the DoD self-help line. This obviously helps, can also help with military sexual trauma. All right, we've got the American Military Family, which is, um, again, to stop the epidemic of veteran suicide. And we've got here locally in Denver, the Bill Daniels Veteran Service Center, which has all kinds of services for veterans. It's a great, 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 great program. All right, lastly, Military One Source is literally that. Anything, I mean, it is absolutely incredible how much is available through Military One Source. 24/7 support, all kinds of different things. You can even arrange to have face-to-face visits, video counseling, all kinds of stuff. Always going to have the Veterans Crisis Line in here 14,000 times. And I just wanted to add my agency, my community mental health agency, Jefferson Center for Mental Health, and I am the clinical case manager and the Veteran and Military Family Services program, which, yes, I'm biased, but it's a great program, getting even better. So here are my references. Last page of references here. All right, well, just under 40 minutes. I think that is a new record for me. Thank you so much for listening to my presentation. Please reach out to me if you have any questions, comments, or concerns. All right, thank you so much. Take care.